With Malcolm, so I'm from Northern Queensland and Malcolm's top end, and I wanted to talk about, we want to talk about continuous quality improvement in primary and specialist healthcare. And I thought what I'd outline is a project that we did in the Kimberley, where I used to work, and I've done with Jay, looking at continuous quality improvement, which was part of this SSRS project. And then compare and contrast and explore the synergies between that and continuous quality improvement in primary healthcare, which many of you may be becoming involved with as part of the ABCD process that's running out into primary healthcare at the moment. So what I just wanted to do was, what we're going to just do briefly is talk about the what, why and how, and particularly the doing it component of continuous quality improvement in healthcare, really, in this setting. The key thing about quality's sort of got that name where you sort of hit over the head with it sometimes, but quality is a process, but it's also an attitude, and I think most of us are committed to quality in the healthcare that we provide. None of us goes to work in the morning planning to not do an excellent job for our patients. None of us plans to harm our patients. Quality gives us the tools to figure out how good a job we're doing, and it also gives us the impetus to actually explore and review our practice, and then change practice, and then to review again. And this is what this cycle of quality improvement's about. So there's nothing mysterious about it. It's just the good thing about it, if you say I'm committed to a process of quality assurance, sometimes you get some more bucks for it. So I think we all do it in our life. So I just want to touch on a project we did from a specialist point of view. And the thing about specialist practice is that it rarely, particularly specialist outreach practice, it rarely relates to one site. You know, in Queensland, our specialist outreach service covers 30 different sites. In the Kimberley, it covered 17 different sites. So with specialist practice, you can't review one service. You really have to review your whole region. So I'll just touch on the site and the methodology we used, what we found and what the implications were. Kimberley's a big place, twice the size of Victoria. It's got, you know, the population of a small suburb. It's about half its population are Aboriginal Australians. The key thing about doing a region or a service-wide quality assurance project, if you're a specialist, particularly if you're a specialist service that works across a range of service providers, is you've really got to get in the buy-in of the providers. Okay, this isn't something you do surreptitiously, it's something you do in partnership. In the Kimberley, there's a very strong and well-organised Aboriginal community-controlled health sector There are 6/7 Aboriginal community controlled health services, and they've got an umbrella organisation called the Kimberley Aboriginal Medical Service Council. So it's really important, if you're going to do this sort of project, you actually do it with the ACHs, you do it with the other providers. In this case, the great thing in the Kimberley was that our specialist, or the specialist service, actually is provided into the ACHs as well as the government clinics, so that works in your favour. The other great thing about the Kimberley is that there's an umbrella organisation you can liaise with. So sometimes if you're a specialist, you're often employed by the state government. It's great to have an organisation you can liaise with, like CAMPS, you know, an umbrella organisation. So this project looked at 17 sites across the Kimberley, and there are bigger places like Broome and Derby and Kununurra that have a big W or a Coles. We looked at was how well we were doing the job. So you develop a tool to measure what you're doing, and you have to make sure that that tool comes with pretty clear instructions for interpretation. You then need to benchmark that against what you should be doing. So you need to, before you can do quality assurance and enter into a cycle of continuous quality improvement, you have to have an idea of what you're trying to achieve in the first place. That's why we need regional protocols and procedures that we all agree on. And then, as I said, a combination of primary and specialist care. In the Kimberley, we've got these, well, when I was there, we developed them, and, you know, it's chronic disease for idiots, essentially, which was sort of me. Nothing can ever be simple enough. So we'd actually reduced the management of rheumatic heart disease to an A4 size sheet. But we adopted the same principles. A combination of best practice, evidence, and pragmatic reflection of how systems work in your area. They're all pretty much the same. You know, if I look at the Queensland Chronic Disease Manual, which I was involved with writing, you know, and the most user-unfriendly 470 pages of, you know, we call it Bible paper, you know, as soon as it gets Bible paper, that I've ever seen. But when I look at that, they all say the same things. It's just how you say them. There are differences, okay? And that's where I think local, you know, Australia-wide policies and protocols are great, but they also need to be adaptable to the local environment. And that's also, that process of adapting them brings people together who are stakeholders, and it generates that ownership that you need, which I think is also the key thing. So when we developed these, we did these between the government, say for this one, our visiting cardiology service, our the ACHs, the specialists, the physicians, the paediatricians, we all sort of agreed. We had our Barneys and stuff, but in the end, we sort of said, you know, if you can't fit it on one side of a piece of paper, then it's not going to get there. So what we did is we actually, the next thing you've got to do if you're going to have a system of continuous quality improvement is you've got to know your population. Who has the condition of interest? Okay, and we always come back to this: know your population. Not just know your denominators, but actually know who's got acute rheumatic fever and rheumatic heart disease. So there has to be a system of enhanced surveillance. For rheumatic heart disease, what that really means is that if you're really going to do it well, you have to start looking for the cases of rheumatic heart disease that you haven't picked up. You know, the cases of monoarthritis without a bug ascertained. For rheumatic heart disease, what that means is you need to go and find the lists that people have, but then you've got to we went through all the specialist letters and put in rheumatic, mitral and aortic, and did a word search through, you know, thousands of letters that we had. So we had a database of letters. We went through all the echo reports and pulled out all the ones that could have been vaguely consistent with rheumatic heart disease. No, this is Kimberley. That's exactly right. But the key thing is that developing a register is a stepped approach, and one of the key things about developing a registry in the Kimberley at that stage was that you've got to have the information to create the advocacy. Now, you know, because when you go to your regional office, they'll say, well, there is no problem, or we've got lots of problems, so tell me why this one's more important. So you need the information to do it. Even a register is only as good as the information that goes in it. So a register by nature has to have a system keyed into it of enhanced surveillance if you really want to work. So you need to know your population. I think that's the key thing to take. So dredged through all of this stuff, pulled, triangulation, multiple information sources, and we found about 212 people. So that's the good reassuring thing. We're 40,000, so that's not a small amount of 40,000 people, but we found about 212 people. Now, obviously, we're missing people, but that's the known unknown. And we just had a look at that. The key thing that comes out of that, if you know your population, you start getting a measure of your burden of disease. So at least we found out of that our best case scenario is that we had about 1.1% prevalence of rheumatic heart disease in our Indigenous Australian population. Good thing about that is that approximates what we'd expect from other places. It's rough and dirty data, but it's starting to feel real now. Oh, the other thing we did is we just divide them into their severity or their priority of valve lesion. This is, we just stole it from the territory. I'm sure we attributed it somehow to that. All right, we divided it into our levels of severity, who'd had valve replacements. I suppose the key thing was we found of people with rheumatic, of people were on this listing of these 212 people, nearly a quarter of them had actually had a valve surgery, a valve replacement. So we seem to have the pointy end of the spectrum. And as soon as you start seeing that when you do enhanced surveillance, you know that you have under-ascertainment. Because if with rheumatic heart disease, you should have, lots of milds, less moderates, less severes. So as soon as you know you've got lots of severes and less milds, you know you've got a problem with that under-ascertainment. Another bit of useful information. So we looked at, of course, secondary prevention of the people who should have been on secondary prevention, okay? So there might be, how sometimes with protocols, of course, we might extend the LAB longer than 35 in rheumatic heart disease if they're the severes, but it all gets a bit fluffy then. But we looked at the hard and fast rules and looked over the preceding 12 months. And the thing we found was that 3/4 of people had at least had one dose. Fantastic. Yes, in the last 12 months. Fantastic. So the other thing to take away from this stuff is this is not a stick, okay? This is not a stick that you use to sledge people with, because as soon as you do that, they never want you back. Even if you've got good relationships, you'll damage them. Change isn't helped by hitting people over the head. Well, it does not long-term change. So anyway, at least some people were getting it. But what we really found is about only 1 in 6 people were getting at least what we vaguely call adequate adherence or uptake, which was more than 80% of their recommended doses. So we've found some issues there. We haven't identified why that is. We're not blaming an individual. We're not blaming the patients. We're not blaming the primary healthcare providers on the ground. All of you could think about, well, you don't have a register. How could you provide good, recall? We know there are multiple issues, but we know at least there's a problem. Oh, the 80% rule is I take from TB. Because I always believe
it came from Sophie.
Is that right?
Sophie said.
But 80%'s the TB rule.
In her book. No, it's but the 80% still originally came from Australia, from her. And it's the chapter that she and Jonathan, on the basis that it sounded like a good idea at the time, and but it came from here.
But one could argue, as far as proportional uptake of adherence,
there was some cover at 80%, and so Day and Jonathan wrote the chapter, and that has how it was stayed. So the benchmark is literally where we drew it.
Yeah. But it's clear that as far as uptake of secondary prevention, what we should be aiming for is 100%, without a doubt. But yeah, or 16, as the case may be. All right. Now, because we keep this towards specialist practice, and in a way this can work well, because from our point of view, we saw that this was before ABCD was being rolled out. We saw if we reflected on ourselves, we've got broad shoulders, we can at least start saying something about our own specialist practice, which I thought was an important step in introducing the concept of quality into our practices, our service as a whole. So what we did is we divide them into the priority groups. And we have a visiting cardiology service, and our protocol says that it's really just the high priority lesions that require